plays in the delivery of healthcare services, and that these gaps really stem from a lack of recognition as to the importance of effective communication and how this impacts the health system as a whole. Regarding the third construct, stroke patient outcomes, the American Stroke Association has asserted that comprehensive picture of a patient's outcome, or how well a patient does after a stroke, can be measured by looking at readmission rates, length of stay, treatment-related complications, disability rate, and mortality rate, which are also quality indicators. Duplessis, Gerber, and Brand examined the relationship between quality of care provided to stroke patients and outcomes. They found that there was a direct correlation between quality of care and patient outcomes. Finally, Lakshmirian et al. In 2011 determined that once a patient actually has a stroke, the focus becomes about the prevention of another stroke as well as about the recovery from the initial stroke. This is a literature review map that depicts the study's constructs. Each construct was informed by 5 indicators, and the literature review then informed the development of the 2 research questions, which we'll talk about in greater detail later on during the presentation. The study consisted of 3 constructs that included continuing education, communication competency, and stroke patient outcomes. For the purpose of this study, continuing education was defined using the Accreditation Council for Continuing Medical Education's definition, which states that continuing education consists of educational activities which serve to maintain, develop, or increase knowledge, skills, and professional performance and relationships of an individual within a particular profession. This was the independent variable for the first research question in my study. Continuing education improved individual knowledge base and competency level, leading to the convergence between what is best practice and what is common practice. Additionally, regular training is a requisite for effective communication. Previous literature yielded 5 dimensions that are common to continuing education. These dimensions included improving physician clinical care, physician communication training, changing physician behavior, minimizing patient complications, and improving patient outcomes. The second construct of the study, communication competency, was defined by the objective, structured clinical examination for physicians as verbal and nonverbal words, phrases, voice tones, facial expressions, gestures, and body language that are used in the interaction between 2 or more individuals. Communication is an important part of the relationship process. Communication was previously established by literature as essential to building and maintaining good physician-patient relationships, as well as good physician-colleague relationships and patient outcomes. Additionally, physician communication must be effective, can impact or be impacted by culture, and numerous survey tools are used to measure physician communication. The third construct of the study, stroke patient outcomes, was defined as how well a stroke patient recovers. Measures of stroke patient outcomes can also be indicators of a healthcare organization's care quality. Stroke patient outcomes for the purpose of the completed study was measured by readmission rates, length of stay, treatment-related complications, disability rate, and mortality rate. This was the structural model for the conducted research study. As you can see, there is a relationship between the 3 study constructs. The model demonstrates that continuing education and communication impact stroke patient outcomes. The model also states that continuing education and communication would improve communication competencies of hospitalists, and hospitalists' improved communication competencies would impact stroke patient outcomes. The literature revealed 2 significant gaps. First, few continuing education models have been evaluated for their impact on patient outcomes, and prior research really hasn't examined the intersection or interplays among the three study constructs in a single setting. Second, further empirical investigations are really needed to better understand the role of communication in healthcare service delivery and to recognize the importance and impact of effective communication. Therefore, the purpose of this study was to examine the relationship between hospitalists' continuing education and stroke patient outcomes, and to explore the relationship between communication competencies as developed through hospitalists' continuing education and stroke patient outcomes. In order to do so, a mixed methods approach was used to analyze qualitative and quantitative data. I just also want to take a moment to mention that I'm really passionate about this due to my job as well. I see a lot of these issues firsthand. For instance, a patient might not have any idea what to do upon hospital discharge just simply due to poor communication. So in my opinion, there's really a great need for this study based upon what I've seen working in the field. The study was broken down into two main research questions. The first research question was quantitative in nature and was as follows. Does hospitalists' continuing education and communication impact stroke patient outcomes? The hypothesis was that hospitalists' continuing education and communication will impact stroke patient outcomes. The second research question was mixed methods and was as follows. Do hospitalists' communication competencies that improve through continuing education efforts impact stroke patient outcomes? There were two propositions that were associated with the second research question. The first proposition was that continuing education and communication can improve communication competencies of hospitalists. The second proposition was that hospitals' improved communication competencies can impact stroke patient outcomes. Study participants for the first research question were U.S. hospitals located in the Midwestern region of the United States that provide stroke care. The Midwestern region was defined by the following states: Iowa, Indiana, Illinois, Kansas, North Dakota, Nebraska, Michigan, Minnesota, Missouri, South Dakota, and Wisconsin. The Midwestern region of the U.S. was used as this is the area that this researcher felt she could make the largest impact in, especially regarding health policy. In this study, 284 hospitals had archival data that was analyzed. Study participants for the second research question were physician hospitalists. The survey was administered twice. The first round was sent to one physician hospitalist at each of the 284 hospitals used in the first research question. The second round was sent to 227 contacts whose hospital had no response during the first survey round. Of note, some hospitalists did forward the survey on, so a single hospital may have had more than one survey respondent. Of the survey sent, 65 responses were received. This meant that the study actually had a 22.9% survey response rate, though surveys were then further excluded if they were incomplete. The final sample was 42 clean survey responses. Data were collected only after the dissertation proposal presentation was completed. The dissertation proposal was approved, IRB approval was obtained, and permission from the American Heart Association was received. Archival data was used to collect data for quantitative analysis for research question 1. Two separate databases, which included the Professional Education Center and the Get With the Guidelines Stroke database, were used to collect data for this completed study. De-identified stroke patient data for readmission rates, mortality rates, disability rate, treatment-related complication rate, and length of stay was collected by hospitals in this database for the calendar years of 2015 and 2016. Data were also collected via the Professional Education Center, and hospitals that participated in courses with communication competency as a learning objective were reviewed. Regarding research question 2, primary data was collected via an online survey for qualitative and quantitative analysis. The online survey was adapted from the Kirkpatrick model of continuing education, and questions were created that discussed hospitalist experiences of continuing education and communication. The survey was comprised of 6 demographic and 4 open-ended questions, and survey logic was in place that ensured the correct group of individuals responded to the survey. For instance, if a respondent answered no if the physician was a hospitalist question, the survey would end after that response. The survey was sent to 2 content experts for review. A pilot of the survey was conducted by 5 hospitalist physicians, and the survey was then sent to hospitalists, including neurocritical care physicians or neurohospitalists who treat stroke patients. For research question 1, descriptive and inferential statistical analysis was completed using Minitab. These included measures of central tendency, dispersion, frequency analysis, correlation, and tests such as ANOVA, linear regression analysis, chi-squares, and Cronbach's alpha. This list is really by no means inclusive, but it was the starting point for analysis. For research question 2, quantitative analysis, as indicated in the previous slide, was conducted on the demographic data included in the survey, which was age, gender, highest level of education, training in a specialty field, and hospital practice. Additionally, qualitative analysis was completed on the 4 open-ended survey questions using NVivo. NVivo was used to code, sort, link, and model qualitative data gathered through the online survey. From the coding, different themes emerged which supported the propositions. The study was appropriate as it sought to provide insight into a research gap, which was examining the relationship amongst the 3 study constructs in a single contextual setting. It was ethical, and no harm came to participants, and all data that was used contained no identifiable information. In terms of hospital type, there were 231, or 81.3% of nonprofit hospitals, 23, or 8.1% for-profit hospitals, and 30, or 10.6% governmental hospitals in both 2015 and 2016. More than 3/4 of the hospitals, or 78.2%, had more than 100 beds. A majority of the hospitals, 55.3%, had over 1,000 employees. More hospitals were located in urban areas, 70.8%, than in rural areas, which was 29.2%. Additionally, the results of the chi-squares test performed to determine quality of distribution were statistically significant at a p-value of less than 0.001 for hospital type, bed size, number of employees, and hospital location. This slide reports on the intercorrelations between the number of continuing education and communication classes and the 5 indicators of stroke patient outcomes, which were readmission rates, mortality rate, disability rate, treatment-related complication rate, and average length of stay for 2015. This slide reports that at a p-value of less than 0.05, continuing education and communication was not significantly correlated with all 5 indicators of stroke patient outcomes. 3 indicators of stroke patient outcomes, readmission rate, disability rate, and treatment-related complication rate, were negatively correlated with continuing education and communication. 2 indicators of stroke patient outcomes, mortality rate and average length of stay, were positively correlated with continuing education and communication. This slide reports on the intercorrelations between the number of continuing education and communication classes and the 5 indicators of stroke patient outcomes for 2016. The slide reports that for 2016, at a p-value of less than 0.05, continuing education and communication was significantly negatively correlated with 1 indicator of stroke patient outcomes, which was readmission rates, and not significantly correlated with the other 4 indicators of stroke patient outcomes. 3 indicators of stroke patient outcomes, readmission rate, disability rate, and treatment-related complication rate, were negatively correlated with continuing education and communication, while 2 indicators of stroke patient outcomes, mortality rate, and average length of stay, were positively correlated with continuing education and communication, though not significantly. Stroke patient outcomes, as indicated by readmission rates, had a statistically significant negative relationship with continuing education and communication. The strength of this relationship also doubled over the course of the 2-year study period. This result suggests that the number of continuing education and communication classes offered at a hospital is an independent predictor of readmission rates. Additionally, readmission rates were statistically significantly different between hospital type, with nonprofit hospitals having a lower readmission rate than both government or for-profit hospitals. Analysis of variance, or ANOVA, is a statistical method in which the differences among groups are analyzed. A one-way ANOVA test was performed for stroke patient outcomes and its 5 indicators across hospital type, bed size, number of employees, and hospital location. In 2015, there were statistically significant differences among hospital type, bed size, and location in the readmission rate indicator. In the mortality rate indicator, there were significant differences found among bed size, number of employees, and hospital location. There were no differences found within disability rate, while treatment-related complication rates actually had differences between hospitals based on bed size, location, and number of employees. Finally, there were differences in all 4 indicators: hospital type, bed size, number of employees, and hospital location for average length of stay. In 2016, there were statistically significant differences among bed size, number of employees, and hospital location for readmission rates. In the mortality rate indicator, differences occurred in hospital location, bed size, and number of employees. There were statistically significant differences found in hospital location related to disability rate, while in treatment-related complication rates, differences were found in bed size, hospital location, and number of employees. Finally, there were differences in all 4 indicators for average length of stay. Test-retest reliability was used as the reliability measure for research question 1. Test-retest reliability measures internal consistency amongst the 5 stroke patient outcome measures across a specific period of time, which in the case of this study was 2015 and 2016. Cronbach's alpha was then calculated, and highly acceptable alpha values were found for treatment-related complication rates and average length of stay. Nearly acceptable alpha values were calculated for disability rate. Essentially, face validity is whether or not the indicator measures what it claims to. Patient-related outcomes research is considered valid if the items appear to the subject matter experts to represent adequately the total universe of appropriate content. Similarly to the Walsh, Gompres, and the Rudd study in 2002, face validity was used in this study as it is comprised of 5 indicators of stroke patient outcomes that cannot be calculated into a single composite score. This table explains the second research question's results for the first survey question, which was, how did you as a participant perceive your experience in continuing education training and communication? These results found that continuing education and communication can improve communication competencies of hospitalists. This was an assertion that was overwhelmingly supported by nearly all survey respondents, regardless of demographic characteristics. Out of all statements made by the 42 survey respondents, an overwhelming majority of statements were positive and in favor of continuing education and communication to improve physician competencies, while very few were negative. The main themes that emerged from the first proposition were care, communication, communication training, skills, and the patient, including the patient experience and patient care. This table explains the second research question's results for the second survey question, which was, what were the outcomes of your learning from the continuing education training in communication? There were several differences found based on the demographic analysis of the first proposition. Female hospitalists discussed how communication training improves skills to better treat patients, and the use of communication training to improve patient outcomes and enhance the patient experience. Communication training or skills were consistently discussed in the context of the patient and their family and were 100% positive in their responses. Most male hospitalists were positive in their survey responses, though male hospitalists with 21 or more years in service were responsible for the majority of negative statements. Of the negative statements, survey respondents felt that communication was common sense or that training was redundant. This table explains the second research question's results for the third survey question, which was, how has the continuing education training in communication changed your interaction with stroke patients? Hospitalists' improved communication competencies impact stroke patient outcomes. Overall, survey respondents made 34 positive statements that supported the assertion that improved communication competencies impact stroke patient outcomes, while 18 statements were either negative or only in partial support of the impact that improved communication competencies has on stroke patient outcomes. The main themes that emerged from the second proposition were patient outcomes, rates, treatment, mortality, care, the patient experience, and communication. While overall sentiments were the same across demographic characteristics, there were a few unexpected differences regarding key themes by age range, years in service, and specialty. This table explains the second research question's results for the fourth survey question, which was, what are your perceptions of the impact of your continuing education training in communication on stroke patient outcomes, such as average length of stay, readmission rates, and mortality rates? There were several differences found based on the demographic analysis of the second proposition. Hospitalist physicians aged 0 to 35 years with 0 to 10 years in service and in a non-neurology specialty were less likely to believe that improved communication competency through increased continuing education impacted stroke patient outcomes. However, all other groups, no matter the demographic characteristics, supported the assertion that improved communication competency through increased continuing education impacts stroke patient outcomes. Hospitalists continually stated that improved communication competency would positively influence stroke patient outcomes, including reducing readmission rates, reducing mortality rates, reducing disability rates and associated complication, and reducing length of stay. To summarize research question 1, results suggest continuing education and communication is related to stroke patient outcomes. Readmission rates as an indicator of stroke patient outcomes had a statistically significant negative relationship with continuing education and communication, and nonprofit hospitals had a lower readmission rate than both for-profit and government hospitals. Finally, the results suggest that improved communication through continuing education may be an effective way to reduce hospital readmission rates. To summarize research question 2, results suggest continuing education and communication can improve communication competencies of hospitalists. Results further suggest that improved hospitalist communication competencies impact stroke patient outcomes. During analysis, several key themes emerged, which included communication, patient care, patient experience, and patient outcomes. Finally, there were several differences that emerged based on demographic characteristics, such as gender or years in service. Triangulation allows scholars to document consistent findings by using different methods to obtain those findings. Triangulation increases the confidence of study findings, specifically that such findings are not driven by a single method or data source. Findings from the first research question suggest that continuing education and communication has an impact on readmission rates as part of stroke patient outcomes. Findings from research question 2 support the propositions that continuing education does improve hospitalists' competencies and communication, which then impacts stroke patient outcomes. Taken together, both findings support the assertion that there is a relationship between the three study constructs and address the research problem. First, readmission rates were significantly negatively correlated with the number of continuing education classes and communication, and this rate nearly doubled between 2015 and 2016. This finding suggests that continuing education and communication can reduce unnecessary readmissions within 30 days of hospital discharge. Readmission rates are further linked to payment reforms across the U.S. healthcare system that assist hospitals in reinforcing providers to consistently provide high-quality care to patients. Second, improving communication is essential to team collaboration and patient-centered care. Numerous unwanted effects found in the healthcare environment, such as disruptive behaviors, low staff job satisfaction, high staff turnover, poor patient outcomes, poor quality of care, and increased preventable patient mortality can be traced back to poor communication, collaboration, and teamwork. Essentially, improved communication through continuing education can improve collaboration and teamwork. Hospitals' continuing education opportunities should be changed to include communication. Presently, continuing education and communication is not offered by hospitals as a standard practice. While physicians often do not participate in continuing education beyond what is required by their licensure, evidence suggests that physician competencies can be improved with effective training. Finally, improving communication is considered important for avoiding medical error. However, there has been little empirical study to improve communication within the medical profession. The more training providers receive that teaches effective communication skills, not only between providers and patients, but between providers and colleagues, the less likely medical errors are to happen. The summary discussion of the study results and the implications for practitioners collectively facilitated the identification of several recommendations for practitioners. First, hospital providers are on the forefront of patient care and must provide patient-centered and collaborative care. To provide such care, effective communication is necessary. Therefore, hospitals are recommended to allocate resources for developing leadership competencies, including that of communication as a competency of their clinicians, administrators, and other professionals who are at the forefront of interacting with patients and their families across the continuum of care. Secondly, the opportunities for professional development have been found to positively impact employee engagement, career development, and staff retention. Hospitals are recommended to cultivate a trusting, respectful, positive, optimistic, supportive, and satisfying climate in the hospital workplaces. Hospitals are additionally recommended to provide hospital staff with professional development opportunities to improve communication competencies. Engaging patients as partners help to improve patient outcomes, and communication is central to engaging patients. Relative to patient engagement, hospitals are recommended to additionally establish and implement a standardized process to ensure smooth transitions of care when discharging patients. Finally, it is recommended that medical schools enhance curriculum to include communication training early on in a physician's training. Recommendations for future research. First, A future empirical study may be used to explore the impact of continuing education and communication has on post-hospital discharge patient outcomes, such as mortality and rate and disability rate. Second, research can be done to investigate the impact of communication has on the patient experience by employing a quantitative research design. Hospitals would additionally be able to determine if any differences exist between different races and ethnicities, such differences may be used to help elucidate poor outcomes for minority patients. Third, the role of provider communication and medical errors should be explored. It is estimated that 80% of serious medical errors are linked to poor communications between clinicians, particularly during shift changes. Finally, research can be completed which will examine ways in which to improve communication within the medical profession, and an empirical study can be conducted. The study did have a few limitations. It had a limited scope of data collection in that the data for both research questions was limited to the Midwestern region of the United States, which means that the study results may not be representative of the entire US. Additionally, the study used purposeful sampling in both primary and secondary data collection. And this type of sampling is non-probability and based on obtaining survey responses from hospitalists whose organization participated in Get With the Guidelines stroke, as the study required subjects with the appropriate experience and knowledge of the issues being addressed in the research. Third, the sample size was determined by available resources. Finally, the accuracy of the archival data is limited as the method of data entry into Get With the Guidelines stroke is completed through manual data abstraction. With human data entry, errors will occur. This researcher was unable to verify the accuracy of this database and relied on the database manager at each participating hospital to verify. And then I always think it's good to thank people again. I just wanted to take a minute and thank my dissertation committee, Drs. Dishman, Fick, and Leeming, the DHA chair, all DHA faculty, and College of Graduate Health Studies administrators and academic advisors, as well as Marsha Presley for having me on today. I really appreciate it. And at this time, I would like to open the floor for any questions.
Okay, thank you very much, Kathie. If you want to ask questions, you can unmute yourself at this point in time. I do have a number of questions from Donna. Mm-hmm. Donna, do you want to ask your questions out loud?
There we go. Hi, Kathleen. Thank you. I sent the questions through the chat just so I wouldn't forget them as you were presenting, actually. But you did actually answer the questions in the end. And I was surprised to hear that in one of your slides that communication really isn't a standard of practice that's revisited. I just found that to be surprising. And I'm not debating it, but I just found it to be surprising. And then my other question that you answered in your recommendations was, it appears to be that, you know, the patient, as is appropriate, tends to always be the focus. And like you said, whether it's preventing a future stroke or recovering from a stroke, which is traumatic. My concern was that there just tends to be a lot of emphasis on the patient. But however, the patient is surrounded by caregivers and loved ones and extended family members. And I wondered if any of your training alluded to the inclusion of how to address, support, or even counsel or educate extended family members.
Yeah, we see that all the time because, as I'm sure most of you know, when you're a patient in a hospital, you tend not to hear everything that's thrown at you. So we really stress, at least in my current job, we really stress educating not only the patient, but the caregivers as well, whether they're immediate caregivers or even extended caregivers, because sometimes those extended caregivers can also play a role. This research didn't really delve too much into communication with the family. It was more based on between the provider and the provider colleague. But that would definitely be an area for future research.
Thank you. And you also denoted that in your recommendations, and I appreciate that a lot. I thought it to be a great presentation, and thank you for answering my questions.
Oh, absolutely.
Anybody else want to chime in?
This is Kate DiCaprio. I have a question. When you refer to communication, was it just verbal communication that the provider, the physician had with the patient or extended family that was there? Or did that include, the addition of maybe some documentation? Oftentimes patients, when they leave, especially, patients that have maybe substantial neurological problems, they're sent home with documentation, what to do next, what to look for, stuff like that. Was that included in the communication overview?
Yeah, communication, the term communication in the beginning, it encompassed verbal and nonverbal communication skills, which did include the writing of materials, though physicians are often not really responsible for the written materials. It's more the education department. So.
Thank you.
Yeah.
Anybody else have any questions? Does since a lot of the stroke patients may not be able to effectively communicate, does the training include things like being able to acknowledge gestures or facial expressions, things like that? You mentioned that briefly. How much is included in the training?
Yeah, so it is very much included because stroke patients may have a difficulty in communication, and that's why the caregivers should be included as well. Depending on the disability, that can vastly impact how well the patient is able to communicate.
Yeah. Okay.
Kathie, this is Liwa. Can you hear me okay?
Yes, I can hear you.
One of the questions that I have for you is the results seem to be very interesting to practitioners. Have you had a chance to touch base with those people as you visit hospitals, or have you had a chance to present your results to some of the hospitals?
Yeah, thank you for the question. I actually have discussed my results with several physicians, and I actually have 3 different grand rounds presentations set up for this winter. So I will be disseminating the results that way. I also did a nice poster presentation, which I will be presenting at International Stroke Conference in January, the end of January of 2018. So I have had the opportunity to have some really great conversations with a lot of different physicians.
That's great. As you present yourself, and I'm sure that the audience will become aware of our ATSU, and particularly our CGHS programs. So make sure you say that out loud.
I will, I promise.
Marcia, you're on mute.
I was muted myself. Sorry about that. Dave, you sent a message. Would you like to ask that question out loud?
Yeah, regards health literacy, and at what literacy level were the educational pieces at? And then,
sorry.
Secondly, I'm assuming that the health literacy level of the patient is unknown, and is that a limitation for you?
Health literacy of the patient was unknown. All of the materials are written at about a 4th to 6th grade level, depending. And they do go over the materials with the patient. They don't just hand the patient a sheet and say, here you go. They do go through it with them and ask them if they have any questions, both the patient and the caregivers at the bedside. How well they will understand it later, unfortunately, is kind of to be determined. And that could be seen as a limitation, yes.
Kathleen, just tagging on to what Dave was saying, were any of your participants needing interpreters of any kind, or were there any practitioners or consumers provided in your or available in your study that had any type of special need?
As far as interpreters go, that is information I do not have access to, but I know that each hospital I worked with does have an interpretation service, and they do provide interpretation services when it is needed. Regarding other special needs, I don't have. That was not part of the de-identified data that I received.
I understand you did archive data, so I really appreciate it. It might be interesting to look at ethnicity or race of
Yes.
the practitioners or the patients as well.
Yes.
Mhm.
Thank you, Kathleen, for taking the time to present to us.
Oh, it's my pleasure.
Marcia, do you have any other questions?
I'm not seeing any other questions. I do have Kathleen Mathiasen added, congratulations on your work, and thank you for taking the time to share with us.
Oh, my pleasure. I appreciate you having me on. I really appreciate it.
Yeah. So, does anybody else want to ask a question? For sure. Okay, well, I think we're done here, and I very much appreciate you presenting this material. It's very interesting. Thank you, Kathie.
Thank you.
All right.